Ray, thank you very much indeed, and thank you to the Tissue Viability Society for inviting me to speak today. What I want to try and do is explain where the burden of wounds study came from and a little bit about the thin database that it's based on, and then from that move on to some of the data that we've derived. I was very lucky to be asked to be the clinical director of something called the NIHR Wound Tech HTC some 6-7 years ago. And as Mary hinted at with her talk, although wound care is one of the oldest parts of healthcare provision, the data underpinning some of our decisions is well recognised to be lacking at times. And the challenge for the HTC was, how do we inform the development of medical devices in an area of need? And the answer was, we really lacked sufficient data to understand what the NHS needs in terms of delivering wound care. I and the strategic partners that formed the HTC came up with the idea that we would go out to tender to conduct a study to look at what impact wounds were having in terms of their cost and what the outcomes of wounds were. We managed to obtain joint funding from the HTC itself and from industry. And Julian Guest put forward a proposal using the Health Improvement Network, or thin database, as the source of information for us to develop a framework in which industry and healthcare could develop wound care services. And we've submitted reports to the NIHR, to NHS England, to industry, and obviously clarified things with the strategic partners, and also published a series of papers on the burden of wounds study. So, the Health Improvement Network, or thin database, it's a nationally held consolidated database which records all medical activity in relation to patient care from 580 general practices scattered around the whole of the UK. It accounts for something like 6% of the UK population, and there are records of up to 12 million people held within that database. Not all of those are current. There are, I think, something like 5 million current patient records. The data is well structured, so it is easy to extract the data once you understand how it's held on the system. It consists of patient files, therapy files, which include things like prescription data, medical files, which include correspondence from other healthcare professionals to the general practitioner, plus additional data on smoking, other lifestyle events. So you can get actually a very detailed and structured overall picture of patient care. It actually was designed to provide epidemiological research, and has been used in a number of products, both on drug safety, outcome of care research. And the advantage is that it includes a very representative population. Both young and old are included in the database, and these are often populations that are excluded from research-controlled studies. It has a number of strengths. It looks at actual real-world care, the care that is delivered. The population it includes has been shown to represent the UK population as a whole. It can provide a large sample size that you can't get easily from a standard RCT-based project. It contains fairly detailed clinical and prescribing data. It's fairly easily accessible. It's regularly updated. And as I already said, it includes data on population groups that are often excluded from RCT trials. It does, however, have its limitations. It is not contained or extracting data from patients in a research format. it is recording clinical activity data. There is a hierarchy of data. In other words, prescription data is very detailed, validated. However, data on such things as ethnicity is relatively poor and not validated. So as long as you recognize the limitations, it provides a very good vehicle for epidemiological studies. Is thin used? Well, the answer is yes, it's widely used for conducting epidemiological research. And I've just picked 4 areas here to give you examples. On the left-hand side, there's a study looking at bladder cancer, following up a cohort of patients with a number of different treatments to look at their survival. But it's also been used to assess mental health, to look at prescribing of cardiac, antibiotic medication, and to manage or look at the management of individual disease characteristics like type 1 and type 2 diabetes, chronic respiratory problems. Has it been used in wound care? Well, the answer is yes. Julian and I have got some experience in using thin database in terms of therapy delivery on a number of occasions. Julian's also had experience looking at, for instance, nutritional data through the thin database. Are we the only group that have used it for wound care? Well, again, the answer is no. I've just put up on the right-hand side, here's a paper from Nikki Cullen's unit looking at the impact of deprivation on a population extracted from thin database with venous leg ulcers to see what impact it had on patient outcomes. So, what did the burden of wound study set out to achieve? Well, we wanted to find the prevalence and distribution of wounds managed in the NHS in an average year. We wanted to look at resource use, patterns of care, and also healing rates, so that we could establish an overall management cost for wounds within the NHS. We limited ourselves to a degree in that it had to be an external wound, it didn't have to be a dermatological tumour, and for surgical wounds we decided that if the wound healed within 4 weeks, that was an attributable cost to the surgery. If the wound took more than 4 weeks to heal, then that was a wound care cost. So we eliminated, if you like, those issues relating to removing clips after surgery, but relied on patients who have had surgical wound complication. We looked at 1,000 patients, randomly selected with wounds. They were all over 18 years of age. They all had a read code for a wound. And one of the hardest part of the study, actually, was to go through the reams of read codes that are available and extract all those that are related to wounds. We started off with, I think, with a list of 25,000 codes and found that 4,000 could actually have something related to wound care within them. So we were very, very careful at the start of this study to make sure that we picked up the patients with wounds. And we compared the costs of those for 1,000 patients without wounds who were managed within the same GP at the same age group. What this study didn't do was look at wound-related mortality. What we wanted to know was how much the cost was over a year, so everybody had to survive that year. And that may have impacted a little and meant that we underestimated some of the total numbers of wounds. For instance, if you had a pressure ulcer and it was category 4 and you died within 3 months, we wouldn't have included you in the study because we couldn't have extracted a year's worth of data for the costs of managing you. We've also managed to carry out some further studies since the original burden of wound study, looking at a cohort of 6,000 patients with a wound. And I'll give you a little bit of data on both these study results. So from the original study, we were able to estimate that the NHS treats an incredible 2.2 million wounds a year. That seems a huge number. Now, a lot of those are relatively minor wounds, which may have only had 1 or 2 nurse attendances to deal with them. However, a number of those patients continued throughout the year of practice to attribute costs. The bulk of the wounds tended to be in the lower limb. And you can see here a fairly wide distribution of wound types. These were the actual calculated number of wounds of each type. Leg ulcers were the predominant group. As you can see, there were, however, 250,000 patients with surgical wounds requiring continuing care beyond 4 weeks of their surgery. So these are significant numbers of patients. We found that there was about 170,000 patients with a diabetic foot ulcer. It's remarkably similar to the numbers that came from the diabetic foot group study looking at the same type of thing, finding that something like 5% of the adult diabetic patient would have a foot ulcer within a year. Pressure ulcers, I think, were slightly lower than we expected. And I say that might be related to the way the sampling is done. We may not have managed to capture patients, for instance, from nursing homes, where there is likely to be a higher incidence of pressure ulceration than there is in the general community of the same age group. By far the largest group were the patients with leg ulcers. And I think this is important, and it's why Brenda's work is so important, because I think getting leg ulcer care right is something that we've neglected for some time. It is a huge proportion of the wound care workload. Venous leg ulceration was slightly higher than expected, nearly 280,000 leg ulcers being treated in a year. Numbers don't always attribute directly to costs, and the most expensive group, even though they weren't the largest group of patients, were the management of patients with unhealed surgical wounds. And you can see the other major groups were the leg ulcer patients, the pressure ulcer patients, and the diabetic foot group. Worryingly, as we all know that you need a diagnosis to treat something properly, a number of the groups that had large patient numbers and large costs had no real diagnosis attributed to them. They were either an unspecified leg ulcer, an open wound, wound type unclassified. And I think that's worrying because treatment guidelines don't address any of those wounds. There aren't any treatment guidelines for an unspecified wound. Yet they account for a very large number of the population in terms of what is recorded within the patient database as the diagnosis. Just to put it into context, you can see wound care features amongst the top 5 major cost drivers in the NHS. And if you just break it down, surgical wounds cost as much as asthma to manage. So I think it's an eye-opener about how much is actually spent in treating wounds and the patient's comorbidities associated with them. Particularly as this doesn't include the social costs of these wounds. Where's the money spent? Well, the bulk of the wound care budget is spent in the community, 2/3 of it. However, that's not the same for all wound types. There's a fairly even distribution between acute and secondary care and primary care for acute and chronic wounds. For acute wounds, whereas in chronic wounds, the bulk of the cost is actually held within the community. What about the outcomes? Well, I think these are from the original study, and we've followed these patients out for 24 months, and these give the healing curve for diabetic foot ulcers and venous leg ulcers. Roughly 50% healing rate for venous leg ulcers at 12 months. The worrying thing is that if those patients are followed out to 24 months, healing rate, I think, was 57%. In other words, we've managed to heal 7% of leg ulcers between 1 year and 2 years, which is not very good healing rates. And when you looked at what was happening to the patients, the worrying thing was that very few of those patients were being referred on to see a specialist, had that input from the tissue viability nurse, even though their wounds were not progressing and had been present for a very long time. And I think that was the worrying thing that I took out from the study, was that the system of care wasn't working for the patient. As I said, we've been able to look at another cohort of patients, and this is from the sample of 6,000 patients with wounds. And these were newly diagnosed venous leg ulcers, followed up for a year, 500 of them. And you can see the healing curve was very much the same as we found in the burden of wound study, just over 50% healed at a year. Similar curve for the diabetic foot ulcer. Again, one of the things we noticed from that part of the study was that the DFU patients rarely got offloading if they were getting community nursing care, rarely got involvement of the podiatrists, or their details of care across the system wasn't finding its way into the thin database and their, in theory, consolidated record. The healing rates are worrying because when you start looking at the fact that you're not healing within year and you're carrying over a large number of wounds into the second year of care, the workload figures for wound care gradually increase. And this just looks at the average workload for a CCG caring for 250,000 patients. And from the figures we have, if you assume the input per year is the same, then the workload in terms of wounds to care for will steadily increase year on year. What does this mean? It means that if you put it with the nursing figures, the number of patients needing treatment is going up, but the nursing numbers are going down. And that's what it means in terms of the cost to average CCG. It's going to increase. This is from a paper that's just been accepted for BMJ Open, looking at 209 community-acquired pressure ulcers. And the healing rates, for instance, of a category 4 pressure ulcer, remembering these are the ones that had to survive for a year, was only 21% within a year. Similarly for category 3, it was under 50%. And these are the cost figures of monthly costs for managing. And really for a category 2, 3 or 4 pressure ulcer, the monthly costs remain fairly constant because the healing rates are relatively low. It's only for category 1 pressure ulcers that the costs drop. So hopefully that paper will be published soon and will provide some more data for you to have a look at from BMJ Open. We've also now managed to look at a cohort of 707 venous leg ulcers, surgical wounds. And this is just giving the healing curve for those compared with the diabetic foot ulcers and the pressure ulcers. Again, only 80% of surgical wounds had healed within a year. That means 20% of patients with a surgical wound were still receiving care a year after the onset of their wound. I'm just going to conclude now. These are the results from Catherine, that Catherine put up earlier about where the burden of wound study focused on areas of concern. And I think that it's very important that we take the message that there was a lack of coordination of care and a lack of senior involvement in a lot of patients' care. So I conclude by saying that burden of wound study certainly has raised the profile of wound care on the political agenda. And I think it's highlighted areas that we need to target resources. And by doing so, I hope that we could improve the efficiency of the care that we deliver. reduce costs and improve, importantly, the outcome for patients. Thank you.
So we have time for one question. Anyone with a question?
Heidi Sandoz from Hertfordshire. The complexity of the patients with wounds is increasing, I think, and our sequence certainly showed that. And I think it's showing that the improvement of the wounds isn't just about the wound care. It's about, we've always said it's about the whole patient, but I think it's about a whole team now being around the patient. And I wondered what your thoughts were on that.
I think that's true. I don't think wound care should be solely a medical remit or solely a nursing remit. I think for the patient to truly benefit, it's a question of managing the underlying disease and working as a team to heal their wound. There are things that I can do as a surgeon that the nurse can't do, but heaven forbid I would be the last person to say that I can put a dressing on as well as my wife can. She can certainly heal more patients than I could possibly heal, but the important thing is that the patient has a visible progression of care available to them so that they can make their way up through various levels of expertise and specialist knowledge to get the best care. And I think the system lets people down at the moment because there isn't an obvious pathway, a ladder of care to make yourself or to take the patient through. And I think that affects the nurse that's delivering the care because she doesn't know how to move patients on at times. And I think we've got to get that structure right.
I think my call to the national strategy that will hopefully get debated in May would be to consider that actually we need a specialist team like we have around the diabetic foot, but we need that for the wound care patient now, and there needs to be a route in for people into that.
I agree entirely.
Thank you very much, Peter.